So next speaker is Dr. SARVESH TIWARI. He is going to talk to us about the medico-legal issues. So these are his credentials. He is going to tell us what to do and what not to do with VR practice.
Good morning, everybody. Thank you for that introduction, Dr. Anand. So I'm going to talk about the VR aspect of the medico-legal issues, how to avoid them. As we all know that vitreoretinal branch is a very tricky branch. In most of the times, the prognosis after surgery and all is very guarded. So there are few things which we need to keep in mind when we are taking up and talking to these patients before any procedure. So avoiding medico-legal issues in VR basically involves a two-pronged approach. First, as all the previous speakers have insisted, is effective counseling. And second is meticulous preparation and documentation. Since already the previous speakers have more talked about documentation and all, I'll be spending a little bit more time on counseling. Because as I said before that the prognosis in these cases is guarded, so you need to spend a little extra time with the patient trying to explain him. So preoperative counseling. You have to be very clear to a patient who has a retinal problem that what he has to expect. You don't have to show him any rosy picture before any surgery or any procedure which he has to undergo. The basic fact is that every retinal patient has to understand that he is suffering from a disease. Retinal procedures are not cosmetic procedures at all. And most of the time the outcome is always less than the previous vision what the patient has. So spend a little bit extra time. There should be no preconceived notion, no unrealistic expectations. Many patients, when they come with retinal detachment, they come thinking that once the surgery is done, I'll be seeing everything back again. Unless the macula is attached, that's a different story. But if once the macula is detached, as it is in most of the cases, because without that the patient doesn't usually turn up into the OPD. If the macula is detached, you have to be blunt and straightforward that you are not going to get the vision what you previously had in spite of the best efforts and the quickest efforts. One point which has to be made very clear to the patient that vitreoretinal surgery is repairing the tissue and not replacing it, unlike cataract. In cataract, we remove the natural lens and replace an artificial lens, but in retinal surgery, we are repairing your tissue. That's most of the patients, when they ask me that why can't I get a good vision after retinal procedures, I tell them straightforwardly that your retina is like a car from a garage. Once your car has gone into the garage and it's come out, you cannot expect the same performance as a car which has come out of the showroom. Okay, so that's the simple language which you can use to explain the patients. Always have empathy, not pity on the patient. As most of the patients of retina have very poor vision, they are already upset, distressed. So don't show them pity because that aggravates their mental stress. Give them encouragement, but at the same time, be very frank and blunt about the prognosis part. Tips in handling difficult situations. Most of the times when patients come to you with complex retinal diseases like diabetic TRDs and all, so it becomes very difficult to make them understand what the problem is. It's not as simple as saying them, you have a cataract and we'll put a good lens and all. So use a very simple language to explain them and use appropriate words. Many times when patients come to me saying no, that what has gone wrong with them and they have bled into the eyes. So for example, a patient with a diabetic retinopathy who's had a vitreous hemorrhage. Leaving the technicalities and the actual pathology aside, the simple word what I use is कि I'll just use vernacular language. I tell them कि आपके पर्दे की खून की नस एक जगह पे फट गई है जिसकी वजह से आँख में खून आ गया है. As simple as that. I tell them हम ये खून निकालेंगे and we'll be doing a laser to your eye. So basically a patient has a general idea that what exactly is wrong with his eye. Apart from getting into technicalities that we'll do this, we'll do laser, we'll do fluid air exchange and all that. That is none of the patient's concern. He wants to basically understand in simple language what's wrong with him so that even if he doubts what you're saying, he can always take a second opinion. But basically one thing which should be clear, that patient should know what exactly wrong with him. We can't just keep rotating the patient from one clinic to the other. Based on your language, on the cognitive ability of the patients. That's what the same point I insist on. If the patient is intelligent, educated, use a different way of communication. If the patient is from a village background, uneducated, use a different way of communication. There are certain warning signs, especially in patients who have not had a very good surgical outcome post previous surgeries. Suppose if the surgery has not been successful, as happened in many of the vitreoretinal cases, there are certain warning signs like see the body language of the patient and the relatives. The moment they enter your OPD, look at their facial reactions. If they are not talking too much, they are raising their voice. These are all warning signs. As we know, tali dono haath se bachti hai. If you feel that the attender is raising your voice, you become calm down. But that doesn't mean you should get bullied. You have to be very firm on what you're talking. Okay, but be in a soft language, be firm and try to explain them what's going on. Avoid taking phone calls during discussions, especially in pre-operative counseling, because that is taken as a very casual approach. One thing which is there here in a retinal surgery patient, as I said, most of the patients are depressed. They have there's something grossly wrong with their eye and they have lost the vision. In that is the time when patient is actually analyzing you. Each and every word that you speak, patient is listening to it and trying to derive some information from it. Suppose in this serious talk you get a phone call and you start talking on that phone and go away for 5 minutes from there, then that link is broken. Then after that, when you return back, you might not be in the same state of mind because you don't know what chat you had with on the other side. And then the patient also not able to connect with you. And the patient feels that this doctor is very casual in his approach. You might altogether lose that patient. You'll not be able to take him to for the surgical procedure as such. And as Dr. Ashish also very nicely pointed out, no loose talks or casual discussion with colleagues. The same thing. Don't discuss these because, as I said, patients are very attentive. They are listening to every word. Even when you're talking to one patient, there's other patient waiting, especially in multi-speciality hospitals where you have heavy OPD. Don't do any loose talks because the other patient listens to how you consulted the previous one. And then they derive a lot of information from that. Okay. Operative cost. Very important point. Never refund any amount. This is the golden rule. If suppose 30% of your VR surgeries are not as successful as you thought, never ever refund any amount. Even if the patient says कि नहीं operation अच्छा नहीं हुआ, पैसे वापस कीजिए, never do that. Even if you do it out of courtesy, it is always interpreted by the patient as a surgeon's mistake. He feels that there's something wrong on your part, that's why you want to compensate it by refunding the amount. So never refund any amount. Don't do any surgery free of cost. This is as previous speakers have already stressed on this point. Be polite but firm in your talk. Referred patients. What do you do when somebody refers, especially your anterior segments colleagues are referring patients to you? As you can see this case, there is some cortical debris in the anterior chamber. So remember, these patients are referred. An anterior segment surgeon has referred to these patients to you with having a lot of trust in you. He knows that you are his colleague who's going to help him out of this situation. Remember that many times these patients, when they come to know, they are not aware of all the facts from the previous surgery. Okay, so first you listen to the patient and derive that unless the previous doctor has spoken to you and told you, okay, chalo, maine ye is patient ko kaha hai. You speak to the patient and you ask him why you have come here, why the other doctor has referred to you. Listen to their version of the story. Don't just open your mouth and say, no, there's a lot of cortical matter left here and there, and don't say that way because that will create doubt and will malign the image of the referring surgeon to you. So listen to the patient what he's saying. Convey to him in a very subtle manner, which doesn't degrade the referring surgeon to you, and the patient understands. Usually what I do in such cases, just for an example, if I see any patient, what I understand that there's some cortical matter left behind. Never lie to the patient. Tell him that cortical matter is there. But how I say that your cataract was very hard, the anterior segment surgeon has tried best of his ability and he's put a lens also. Only a few cortical matter is left behind, but nothing to worry, it can be easily managed. So that gives patient a lot of satisfaction. He doesn't panic. He knows that whatever is wrong, there is some minor issue which this doctor will take care. Same thing, have empathy with the patient. Take your full fees. Just because the patient was referred to you by anterior segment, he might be your friend, but you have to charge him your full fees. The referring surgeon may waive off 50% of his charges. You shouldn't, because you are doing your work. Okay, you should not pay for somebody else's mistakes. Skillful talking and patient listening is the key in such cases. Now coming to the documentation part, as in most of the vitreal surgeries, we don't have a fundus view. So always make it a point, even if you see a patient of vitreous hemorrhage, don't just assume that he's just having a hemorrhage, I'll go ahead and do the surgery. No. If you have access to a preoperative B scan, go ahead, do it. Look whether there's an underlying RD, is there any PVD presence is there, that might be a hidden tractional retinal detachment. Look out for these points. Same comes to if you have access to a good OCT, which most of us have nowadays, Look, if you see a ERM, even if it is clinically visible, do an OCT if it's accessible. You might just see a lamellar hole sitting there. Many times you might feel that the fundus looks normal, but there might be a vitreomacular traction, subtle one. Intraoperative OCT is also an excellent way of, especially when you do macular hole surgeries. And yeah, if any cases of intraocular foreign body comes to you, always do a radiological investigation. It might be as simple as an X-ray. It can be as complicated as a CT scan to know the exact and precise location. Now, as the previous speakers have also said, consent forms are now freely available on the websites of All India, VRSI, DOS, and Bombay Ophthalmic Association. Utilize, don't make your own consent forms. These consent forms which are there have been reviewed and made by experts over years of experience, and they cover all the minute points. Remember to take consent even in minor procedures like subtenance injection. Many times people have a habit of taking, if you have to do 3 sittings of pan-retinal photocoagulation, people will just take one consent and call the patient on 3 different dates. Never do that. Take 3 separate, each consent for each sitting, done on specific dates, because otherwise later you might land up with trouble. Consent should always be written, never any oral consent. Any invasive procedure you are doing, you take it in writing with the patient. Take the patient's own language if possible. Consent should be informed to the patient, and consent must be signed by the patient except in cases of minor or mentally unstable patients. Now, when it comes to injections like Avastin, as we all know, in the past, a lot of litigations and issues had involved when the use of Avastin. We had a phase in between where we had many cases with many patients landing up with infections and all. So when you are dealing with these injections, remember that you have to let the patient know that Avastin is an off-label use. It is widely used all over the world, and make these specific points they should be included in your consent form so that the patient later doesn't come and fight with you that why I was given this injection and all. This is to give you an idea about the consent forms. This is just to give an idea about the litigation issues which we had. So many patients had lost their vision. And because of these issues in between, the government of India had withdrawn Avastin for some time in between, due to which a lot of vitreoretinal surgeons faced tremendous hardships because most of the patients were not very affording in our country. So Avastin was not available. So they had to either switch to expensive biosimilars or the original molecules. So just to give you an idea, what are the current injections which are approved? See, in anti-VEGFs, Avastin is off-label. It is not approved till now. FDA approved include injections like Accentrix, that's same as Lucentis, Eylea, and Pagenex for wet AMD. The DCGI approved is Razumab, which is a ranibizumab biosimilar, and DGCI approved biosimilar, which is still off-label used by the name of Zybev. ROP I'll be skipping because that has already been discussed by Dr. Anand in detail. So scope for improvement. How do we improve on what all points I've already said? Take feedbacks from the patients and peers if is invaluable. That means after the patient, suppose you have operated on a patient is going, always take a feedback from him. Even if you think you have had the best of the counseling, the best of the services provided to you, but listen, you will come to know of the small minute points which you are lacking if you start taking feedbacks from these patients. Do not react and start disagreeing. If a patient comes to you saying that A doctor told him about this diagnosis and this way of management, and you feel that the diagnosis is B and a different way of management, don't react. Just tell them that this is my perspective, this is how I feel things should be done, and never say that the previous doctor was wrong. You always say that was his version, this is my version. This is how I will treat the patient. Reflect and reassess yourself. Many times we do make mistakes, especially in the retinal surgery. Many times there is one disease is managed by different ways. They all might be correct. If you feel that the patient whom you lost and he went to some other doctor and got himself successfully treated, and you come to know the way he was treated, learn from that what you can do next time to avoid that. Show warmth and empathy and not pity on the patient. I already stressed on this point earlier. Closely observing your seniors and peers and developing a professional attitude. This is especially for students and DNB and UMS students. Always see how your seniors are talking to the patient. When you are in your residency and all, just don't work blindly. Even listen to how the doctors talk. Because as I said, counseling is a very important part. It's not just learning surgery. It's learning how to handle the patient as a whole. So a thorough counseling with an empathetic approach, evaluation, and adequate preparation prior to retinal surgery is essential for ensuring a satisfying post-surgical outcome and a happy patient. So in the end, remember that raise your words, not your voice. It is the rain that grows flowers, not thunder. Thank you.
Excuse me, Sarvesh, I had one query. Now, many a times, retina guarded prognosis patients, we send for second opinion.
Yeah.
Now, patient takes second opinion and the second doctor also says the same prognosis. Patient come back to you for to us for surgery. Now, medico-legally, is it a good idea to take a copy of that document and attach to our case sheet, which other doctor has seen? Will it be a valid document in court of law? Because another retina surgeon has also seen, he's noted down his findings, has mentioned guarded visual prognosis surgery.
Correct.
So I will be operating. Suppose if I keep a copy of that with my case sheet, is it a medico-legally valid document?
See, that is important when you have referred the patient for a second opinion. Okay. If the patient is himself going on his own, it is immaterial to you. He has done it for his own satisfaction. But yeah, if you think that many times you'll see in very bad cases, even we as vitreoretinal surgeons, we want to refer it to higher center. We sometimes refer the cases to Shankar Netralaya. We tell them, no, you go to a higher center, because we think that these institutes will do a better justice to the patient. You definitely have to mention that on your paper. If you like, there's a stage 5 ROP. Okay, I think the stage 5 ROP will be best managed by somebody who has expertise in that field. So I'll mention on the paper, refer to higher center for the management of stage 5. That definitely counts in the court of law.
Yeah, no, but you have referred if the patient comes back to you for surgery.
Yeah.
So
yeah, definitely. See, when the patient comes, you have it on paper, right? But the patient, it has happened with me, to be very frank. There was this young 32-year-old diabetic lady was bilaterally very bad tear, type 1 diabetic, very bad tractional retinal detachment, and she has very high expectations. She was related to one of my professional colleagues in Mumbai only. So I told her that it's better you go to a higher center like Shankar Netralaya, they'll do a better justice to you. I spoke to Dr. Pramod Bhende, referred to the patient. The patient went to Chennai, showed him. Then she called me up, she panicked, she said, I don't want to get operated here, I want to get operated by you only. Now I was in a dilemma because I had spoken to the case with sir, finalized everything. The patient came back to Bombay and she said, I want to get operated by you. I put it on paper. That patient was referred, was spoken to Dr. Pramod Bhende. Patient still wants to get operated by me. By God's grace, today after 2-3 surgeries and all, she is still seeing. But yeah, it definitely counts in the court of law. Sure.
Thank you.
Sarvesh, do you advocate in drawing diagrams for the patient while
Absolutely.
explaining? And do you need to document that also in the case sheet?
We in Arvind have always been taught that you have to draw all your diagrams. We have the habit, like the institute where I joined in Bombay, initially the drawing of it was not given so much of importance, but I started making it a point that we draw and we use color pencils.
Yes.
We actually use the color coded which we have been taught in our PG days. Red, blue, green. We have those bunch of color pencils still in my OPD. You don't write, it's okay. But if you draw, a person who is even casually glancing your papers knows just by your diagram what you mean to say and what the picture was.
You're supposed to attach it to a case
Absolutely,
sheet also.
absolutely.
Do you take any signatures or something of the patient while explaining?
No,
Nothing.
I don't.
You just attach it.
We just attach it.
Thanks, Sarvesh.